name is Dr. Sarah Lee. I know most people in this room, but I'll do a brief introduction. So I am a family physician by training, and I do maternity care, and I also have specialized training in addiction medicine. So I'm one of the physicians who provides perinatal addiction care here, and I'm also the perinatal addiction physician lead, I just have to think that out, for Island Health. And I also do addiction medicine, general addiction medicine. So here, 1 week a month, I work on the addiction medicine consult service. And I always want to start, I think we should acknowledge that we're on traditional, ancestral, and unceded territory of the Coast Salish First Nations, where we're learning, working, and organizing here today. And especially because a lot of the women that we are working with are Indigenous, and we always have to remember how significantly that impacts the care that we provide and the experience that they have. So, objectives. So when you guys leave here today, here's what you're going to be able to do. You will be able to describe the epidemiology, which means the trends in substance use in pregnancy. You're going to be able to describe how addiction is actually a chronic disease. You'll be able to describe and tell people how we diagnose addiction, and explain to people why we need to treat these patients. So to start with epidemiology, so what this is just looking at trends and patterns of substance use in a population. These numbers are really hard to come by, specifically for not only the general Canadian numbers, but here in BC for lots of different reasons. The best data that we have is now quite old, actually. It's from the Canadian Perinatal Health Survey. It was back in 2008. And they reported about 5% of women in pregnancy reporting illicit drug use. And what we always have to remember is there's underreporting in these studies because women, even if it's said to be anonymous, are not going to want to disclose that you're using illicit substances for a number of reasons. And the other thing in terms of underreporting is that I do not believe that the Northern Territories were included in this database, and there is likely a significant amount of substance use. So this is like low guess that at least 5%. So when we look at that, what does 5% mean? Sometimes percentages aren't that easy to understand. So when we look at the number of live births per year, that's about 20,000 babes born in Canada per year exposed to substances. And we look at around 3,000 births per year in Victoria. That's about 150 babes born in Victoria per year that have been exposed to substances. There's another database that's just specifically out of Ontario that has, it's a bit more recent and has a bit more specific numbers, but they found about 0.25% of mothers reported cocaine use and methadone use, and about 0.75% of women reported other opioid use. Our numbers are pretty similar to numbers in the States. So there was a survey done in 2012. Again, these numbers are getting old, but show similar numbers. So about 16% of women using cigarettes, about 8.5% drinking alcohol, and about 5.9% of pregnant women using illicit drugs. And marijuana is still considered an illicit drug in the United States database. I think this is probably the most important slide when we're talking about the impact of and the prevalence of substance use. This is just looking at opioid use, and what this is, it's the most recent data that we have. It's the number and rate of total apparent opioid-related deaths by province and territory in 2019. And so the dark purple is the highest. And so you can see we in British Columbia we've had 551 deaths per 100,000 population. So that's huge, right, compared to the rest of the country. So we have, I think we have the responsibility to learn about this disease and properly educate providers, patients, families, and treat appropriately. So what I want you guys to leave here today is understanding that addiction is a chronic brain disease. I'm not a I can't even say the word. I'm not great at neuroanatomy, but I do understand the basics, and that is what I'm going to portray to you guys. So when we're talking about substances, specifically we're talking about how they impact the dopamine pathway. So dopamine is a neurotransmitter that is naturally found inside our body. So it's a chemical that our own body makes in response to reward. So when we're looking at the function of dopamine, it's involved in reward, motivation, pleasure, euphoria. There's some motor function involvement, and that's where we see Parkinson's in dopamine, but that's not so much impacted by substance use. It also functions in behaviors like compulsion and perseveration. So why is the dopamine pathway so important? Well, we look at sort of what natural rewards elevate dopamine. So things like food and sex cause a dopamine surge. But when we look at this and we think about it, reward comes with time and effort. So we used to have to go forage and hunt, prepare our food. Now we go to the grocery store, forage. We prepare food, it takes time. then we enjoy our meal, then we get our dopamine surge. I'm not going to go into the details about sex, but sex doesn't just happen, we prepare, etc. So we get a bit of time, then we get a dopamine surge. What I want you to pay attention to as well is the number. So food, we get this is percent of basal dopamine output, it's about 150, and with sex it's about 200. So these are natural rewards that elevate dopamine levels. When we look at the effects of substances on dopamine release, we see that the time is much shorter for many substances and the percentage is much higher. So specifically when we're looking at amphetamines, look at that, it's about 10 times a natural reward, right? So that's about a 1,000, 1,100% release compared to 150, 200. And the time is much shorter. Cocaine and nicotine also have a more immediate release, not quite as high of a dopamine release. Morphine's a bit more delayed, and unfortunately we don't have a lot of data around fentanyl and where that fits in this picture, but it's likely a more immediate reward than morphine is. So what we're seeing is that your brain is used to having put in effort and time and then get a dopamine response. When we use substances, there's minimal effort and time and immediate huge surge in dopamine that your brain is not prepared for. So what your brain does is it actually, over time, with repeated exposure, reduces the number of dopamine receptors you have, and it also reduces the amount of dopamine that's actually produced, because your brain can't deal with that much dopamine. So if you think about it, the first time someone uses a substance, they have this huge dopamine surge, they have the euphoria. The next time, and over time, that is going to go away, and eventually, they're actually running on a deficit of dopamine, and they need these substances to simply not feel unwell. So your brain changes as a result of exposure to substances. Something I think that's important to understand too is often people will say, well, it's a choice to use drugs. Yes, it is a choice the first time you use a drug. It's a choice that's often made because of a history of trauma, significant trauma. Witnessing or experiencing domestic abuse, sexual abuse, detachment, abandonment, huge traumas that we cannot even begin to understand, and that is a coping choice that they make. So what happens, you make a choice, you use, and then you have to use to actually not feel unwell. And what we see over time is that we see functional changes in our brain. So I don't have a pointer, but on the left side of the slide is the control. So these are functional scans of brains of people who do not use substances. On the right side of the slide, it's labeled addicted, which I don't really like, but anyways, so that's the brains of people who are chronically exposed to substances. And the substances are cocaine, methamphetamine, alcohol, and heroin. And so what you see is over chronic exposure actually reduces activity and metabolism in your brain. So we're looking at dopamine receptor levels that are lower over time from chronic drug exposure. So drugs change your brain. And like other chronic diseases, there's end organ damage. So, this is a really powerful slide because what it's doing on the left-hand side again, this is a healthy brain and this is a healthy heart. And this is showing metabolism or activity in these healthy organs. On the right side is a diseased brain of someone who uses cocaine, and on the right side is someone with a diseased heart, someone who has heart disease. And you see decreased metabolism in both of these organs. So this is a chronic disease that causes end organ damage. So for many of us, addiction is actually just beginning to become part of the curriculum. So a lot of us went through training without any real understanding of addiction as a chronic disease. And it was sort of assumed that drug addiction is a moral failing or a character flaw, that people are lazy and dishonest. This is not true. We need to throw that out the window. We now understand through neuroscience, looking at advanced brain imaging, that we've seen these brain changes, and addiction is actually a result of brain changes caused by substance use. So when we talk about chronic diseases like diabetes, hypertension, asthma, addiction is the same. There are genetic and environmental determinants. We know there's associated morbidities, so adverse health outcomes and mortality, which is death. It's relapsing and remitting. So we look at our diabetics who get their A1C under control and then they stop taking their medication, or they start drinking pop again and their A1C goes up, right? They relapse and then they remit again. We see the same thing in substance use disorder. It's no different. We know that there's no cure for these diseases, but remission can lead to essentially normal life expectancies. So how should chronic diseases be managed? By primary care providers. access to other care providers, social workers, addiction counselors, and backup from specialized services like specific addiction medicine physicians. When we're looking at maternity care, we're talking about connecting with obstetricians, pediatrics, anesthesia, whoever needs to be involved. And I think this is a really powerful slide when we're looking at treatment outcomes. So these are looking at relapse rate between people who use substances, so drug addiction, and other chronic illnesses. So people who have type 1 diabetes, about 30 to 50% of people relapse. People who have drug addiction, so substance use disorder, about 40 to 60% of people relapse. This is actually lower than the relapse rate for hypertension and asthma. So it's a chronic disease with similar relapse rates to other chronic diseases. So how do we diagnose substance use disorder? So this is a super busy slide, but basically we use something called the DSM. So some of you may be familiar with it. It's the Diagnostic and Statistics Manual, and it's the manual that all psychiatrists and all physicians use to diagnose mental health disorders. So basically what it is, it's a conglomerate of different conditions, and it has a bunch of criteria that you have to meet. So when we're looking at substance use, we look at a specific substance and we see how many of these criteria are met. So for example, say I put drug X because the criteria is the exact same for different, so this could be stimulant use, this could be opiate use, this could be alcohol, this could be nicotine. So it's a problematic pattern of drug X, so let's say opioid use, leading to clinically significant impairment or distress, and is manifested by 2 or more of the following within a 12-month period. So we go through and we ask the patients these questions, and we figure out, do they meet at least 2 of these criteria or more? And the criteria are things like, are they taking the drug in larger amounts over a longer time than was intended? Have they tried to cut down and they've been unsuccessful? Do they spend a lot of time trying to obtain these substances or recover? So you think of that with alcohol, right? People who have significant alcohol use have huge hangovers and difficulty recovering. Do they have cravings or strong desires? Does their recurrent use result in a failure to fulfill major obligations at work, school, or home? Do they continue to use despite having adverse social or interpersonal problems? Are they giving up or reducing important social activities to use a substance? Do they recurrently use in physically hazardous situations? And do they continue to use despite knowing that it's causing their body physical harm? Tolerance and withdrawal are a bit special, so I would not consider tolerance and withdrawal alone, just those 2 diagnostic criteria, because you think about the small portion of patients that we do have, say, on chronic opiate therapy, we know their brains will develop tolerance and withdrawal. So they could have other criteria and meet those, but tolerance and withdrawal alone are typically not considered diagnostic in and of itself, but any other 2. Does that make sense? And then what you might see in the chart when you've seen an addiction consult, opioid use disorder, and then we'll say mild, moderate, or severe. So what does that mean? So the severity at the time of diagnosis is specified by the number of symptoms or criteria that they've met. So if someone's met 2 to 3 of those criteria we just reviewed, they have mild opiate use disorder. If they have 4 to 5 symptoms, they have moderate. And if they have 6 or more symptoms, they have severe substance use disorder. There's also specifiers including early remission or sustained remission. And so what that's looking for is after they've fully met the criteria in the past, that they've now not met the criteria for a certain amount of time. So early remission is that they've been not meeting the criteria, so in remission for at least 3 months, but less than 12 months. Sustained remission is greater than 12 months. So a lot of the women that we're seeing in the hospital, specifically that we're admitting antenatally, are early remission, if that, right? Often they're still actively using. The other thing that you probably see in our consults are stages of change. So this is something that we incorporate into our consults so that we as physicians and also the other care providers can understand where this patient is at in terms of readiness for change. So we start at pre-contemplation. No intention on changing behavior. That's okay, right? I go see someone, they drink, 2 sips of alcohol a day. I always say, where do you see yourself leaving the hospital? You want to go right back at it? You never want to drink again? You want to cut back? You want to go right back at it? Okay, pre-contemplative. We'll talk about why that's harmful, but we give them the same amount of care. They're pre-contemplative, we've noted that, we understand where they're at in their stage of change. Contemplative means they're aware that there's a problem, they're just not ready to start to make a change yet. So they're sort of starting to think about it, they understand there's a problem, they should do something, but they haven't made any commitments yet. Preparation means, okay, yeah, there's a problem, I want to do something about it, and they're starting to make those changes. So a lot of the women that we see in hospital here are in the preparation stage of change. Action is when we're sort of seeing active behavioral modification. Maintenance is once we've seen those changes, they're sustained over time. And then relapse, which we know is going to happen, fall back into old patterns, and then they slip back in somewhere along the stage, right? So it's often relapse, back into action, relapse, back into pre-contemplative or preparation, depending on where they're at. So that's often a modifier you'll see in our consults as well. And it helps you, as a care provider, understand where this person's at with respect to their substance use disease. So in pregnancy, why do we want to treat? I mean, there's obvious reasons, but I think these are important ones to remember, that there are huge potential adverse obstetrical outcomes that can happen from untreated substance use disorder in pregnancy. So from early on is risk of miscarriage and stillborn, abruption, choreo, an intrauterine growth restriction, placental insufficiency, septic thrombophlebitis, preeclampsia, eclampsia, an intrauterine fetal demise, preterm labor, preterm birth, preterm rupture of membranes, and then postpartum hemorrhage. So basically any adverse, like, is there any other obstetrical outcomes that you guys can think of? No, literally, every adverse obstetrical outcome.
Diabetes.
Yeah, there we go. I'll find it, I'm sure it's one more, right? And why else do we want to treat? So we don't only just want to prevent adverse obstetrical outcomes, we actually want to improve this woman's access to care. So we know women who engage in their substance use treatment also have improved maternal nutrition, they tend to have more adequate prenatal care, they reduce the risk of all these adverse outcomes. We know they have improved bonding with babe, and often we see mom and baby staying together, and that's our ultimate goal. We also know that we can reduce the exposure of the neonatal brain to illicit substances, and the ones we tend to be most concerned about are alcohol, cannabis, and hallucinogens. And we also, I think this is honestly, if you're going to remember one thing from today's presentation, children of parents with untreated substance use disorders are at a greater risk of developing their own substance use disorders later in life. So it's huge, the impact that we can make on these babes' lives just by treating these moms. It's huge, right? It's such an important dyad, and we need to take into consideration. Treating the mom is treating the baby. This is also why we want to treat, right? These are two gals that a lot of the nurses know here, and I got permission to share these photos. They both were entrenched active substance use throughout their pregnancies. We got them stabilized. One gal came in and stayed a long time antenatally, like a long time. We called it Hotel Victoria General Hospital as a joke. And she is now 4 months postpartum. She's working full time, and her partner's looking after the baby. Yep. She's in like early remission. She's doing great. She's parenting that baby. That baby is thriving. And she said to me that her admission here was the biggest blessing that she could have imagined. That she was able to find housing, to stay with her partner, to connect, and now she's parenting this baby and she's having improved access to her other child. The other gal, we had trouble engaging her in prenatal care. She didn't actually access any care for the last 10 weeks of her pregnancy. She came here, had her baby. We kept her again for a long time. We advocated, we got her stabilized. She's parenting, right? So these are outcomes that are possible because of the work you guys are doing. It's huge, this work. And this is, think about these babes and their futures, right? We're reducing their risks. So we're not only helping the moms, we're helping the babes. So it's super important, and I'm really grateful for everyone to be open and engaged with this population. And that is all that I have.